Aisha?
Hello, Aisha, are you there?
Okay. So I'll introduce the next speaker and the next topic. So the next speaker is Dr. Sujalakshmi Barali. She is currently working as a associate consultant in the department, emergency department or emergency medicine department in Manipal Hospital, uh, Sarjapur, Sarjapur Road. She has
All
a
right, everyone.
yeah.
Can
Sorry, sir, I think
Just
she was
wait.
having a network
Am I
issue.
audible? Can
Introduce our
please
speaker.
anybody confirm that?
Yes, yes. Hi, Aisha, can you hear us? Sir, I think you can go ahead. I'll ask her to join again.
Yeah. So Dr. Suja has finished her MBBS from Guwahati Medical College. She finished her MRCEM from Royal College of Emergency Medicine, UK, a diploma in emergency medicine, fellowship in intensive care medicine, currently working as an associate consultant in emergency medicine in Manipal Hospital, Sarjapur Road. She's currently here to talk on a topic called as dyspnea, emergency medicine perspective. I thank Dr. Suja to accept this invitation to talk on this topic on a very short notice. And this topic is very important, called the dyspnea, because a patient in emergency medicine has maybe have multiple causes of dyspnea. Let it be acute coronary syndrome or from the pulmonary causes, or there are many other causes. So she will take us to the various causes. How do you approach and how do you manage a dyspnea in acute emergency? Over to you, Dr. Suja. Thank you.
Thank you, Dr. Sudhakar. Good afternoon, everyone. Today, we are here to talk on dyspnea. It's a very common presentation in the ER. It is one of the most common presentation in the ER after chest pain, on which we already had an elaborate discussion by Dr. Niharika. So, what's dyspnea? And what is important in dyspnea is not the presentation. We have to find out what's the cause of dyspnea. How is it present? Because mind you, the management of dyspnea is like a flow chart. You have to pick from the history. So if you take a elaborate history, if you have taken a detailed history, you're almost true. You actually know which line of treatment is the patient going to respond to. So when we talk about dyspnea, it is what is dyspnea? So it's a very subjective sensation. It's a very subjective definition, and it definitely means shortness of breath. So when a dyspneic patient comes to the ER, it is most often it is the ambulance pickup, because these patients at home suddenly they are breathless, so they don't know what to do. They call for help, and then they call for the emergency. They call for an ambulance, and these patients are usually picked up at home. So the treatment of the dyspneic patient usually starts in the home itself, when our emergency medical staff reach home and they see that the patient is breathless, the patient is sweating, the patient might also have chest pain. So that's where the initial assessment and initial treatment management starts. And then they get the patient to us. So in a nutshell, dyspnea is a feeling of difficult breathing, labored breathing, uncomfort breathing, in which the patient is has to take an extra effort to breathe. And they usually come to us with shortness of breath or not getting enough air. Now, when such a patient comes to the ER, we have to look into the patient's age, patient's sex, patient's comorbidities. Very important, because that is how it is also going to guide us. For a patient who comes in, we need to also, when we take a history, when we do an examination, side by side, we also ruling out, and we are also keeping all the differential diagnosis in our mind. That's why it is very important to go stepwise into the causes. So here it is a pulmonary cause. the cardiovascular cause. This was the most important, the most life-threatening. Apart from this, there are the metabolic cause, the psychogenic cause, and the neuromuscular cause. Now coming to the pulmonary cause. A patient might be breathless, and that might, in pulmonary causes, the first cause is always asthma, COPD. For a patient of asthma patient, they will have a prior history. They'll have a prior history using bronchodilators at home. So it is very important to take a history of what is the treatment and what are the comorbidities the patient has. Apart from this, the next is COPD. Again, COPD patients, usually they have a history of smoking. They know they have history of lung infections in the past. So they have a history of previous diagnosis which has been made. And the third is pneumonia. In pneumonia, what happens is patients usually have fever, chills. They have cough with expectoration, usually venous expectoration. So, and then they have history of any, and usually pneumonitis also develops in immunocompromised patients. The patients who have history of prior fever, cough very often. So such patients. The most life-threatening is pulmonary embolism, which is also a cardiovascular cause as well. Acute onset breathlessness, the patient presents with. That is one of the, again, most common cause. Next is malignancy. Any pulmonary malignancy patient might come with worsening breathlessness. You may have distended, as in when you check the neck veins, you'll find there's distension, engorged veins in the neck. You might find crepitations in the chest. So history-wise, they come with a history of a diagnosis and of malignancy. They usually have a diagnosis which has been made, or as in when you take the history, you know, there have been frequent presentations. So those come in the pulmonary causes of dyspnea. Apart from that, also, when you talk about pulmonary, there are also the traumatic causes. Somebody who has a history of trauma, again, tension pneumothorax is the most life-threatening, one of the most life-threatening causes of dyspnea. In tension pneumothorax, the patient would have a history of trauma, and as and when you're examining the patient, you know there's cardiovascular collapse, the patient has unilateral air entry in the chest, the distended neck veins, trachea is pushed. And tension pneumothorax is when a patient comes in a compromised status, and you've made a diagnosis of tension pneumothorax. We don't need a chest X-ray. We don't need any diagnostic. It's a clinical assumption. And as and when you diagnose tension pneumothorax, it's very important to treat it, which we'll be coming to in our next slides. So apart from that, in trauma, again, you might get cardiac tamponade, where these are again traumatic causes of dyspnea. Also, this again, there is an overlapping in the cardiovascular and the pulmonary causes of dyspnea. Then coming to the cardiovascular causes, the most common causes is again, like I said, pulmonary embolism. Then you have acute coronary syndrome. In this, the patient will have a history of chest pain. Patient will say, and then when you go ahead, you get an ECG, it's an MI, chest pain, sweating, palpitations. So this is what will guide you towards a diagnosis of acute coronary syndrome. The next in the cardiovascular causes, again, it comes the traumatic cause. You might also, as and when you do an ECG, you might also come across arrhythmias. You will come across various arrhythmias that the patient might have, and go ahead and treat the cause there. Patient might come across with pulmonary edema, heart failure, acute heart failure. Acute heart failure patients usually have breathlessness, and they say, there'll be pedal edema, puffiness, crepitations on the chest, as in when you check the pressures might be very high up. So that is one common cause of cardiovascular causes of dyspnea. Next is your metabolic cause. In metabolic cause, it is metabolic acidosis. Also, all the poisonings come here, carbon monoxide poisoning, and the most renal failure present as one of the metabolic causes of dyspnea, where there'll be a fluid overload status. You also get in, the most common is diabetic ketoacidosis. In diabetic ketoacidosis, we call the breathing as Kussmaul's breathing. They'll have this rapid breathings, and then patient would have a history of diabetes, and when you do a blood gases, you see the sugars are high up, and you see there's acidosis in the ABG. So that's how you know it's a diabetic ketoacidosis. Next, we come to psychogenic causes. Psychogenic causes, it's basically panic attack, anxiety attack, patient come with hyperventilation syndrome, which this and psychogenic is the most, stable patients. And this is the only cause where you get alkalosis. You find that as and when you do an ABG, you find that there's a carbon dioxide washout, which has happened because of the rapid shallow breathings. That is the psychogenic. Neuromuscular cerebrovascular accidents, other motor neuron diseases like GBS, where you find patients coming with breathlessness. Now that brings us to the most common causes of dyspnea in the emergency department. Obstructive airway disease, asthma, COPD, one of the most common causes. And and these patients, usually you see the patients coming again and again to you because they have a history of asthma, they would have missed their medicines or and they again come back to the emergency. They're usually on inhalers at home. COPD patients, again, they come to acute exacerbations, acute worsening of the chronic obstructive pulmonary disease status. The most common in the heart is decompensated heart failure and cardiogenic pulmonary edema. We have an elaborate talk on heart failure coming up a few sessions later, so this I leave to them. Ischemic heart disease, MI, already been spoken in detail by Niharika. So in MI, you have a patient who's coming with breathlessness and they come with chest pain. And it's not always chest pain, like they may come with chest discomfort, they might be breathless. As and when you check, you find that the saturations might be low as well. You do an ECG, you find there's a MI and go and treat it. Pneumonia, fever, chills, upper airway obstruction, one of the most dangerous causes. In upper airway obstructions, patient come with a noisy breathing. You can hear that in a stridor, at times they come holding their neck, to the emergency, saying, all of a sudden, I'm not able to breathe. And they usually come in that dilemma, they don't know what's happened all of a sudden. So that is, again, one of the most life-threatening causes as well. Pulmonary embolism. Pulmonary embolism, again, acute onset breathlessness. This can happen to anyone, but very common in pregnant females, postpartum status, somebody who had a recent surgery, somebody who's been bedridden, so they're not mobilizing, somebody who has a history of DVT, which has been made, malignant patients. These are the common patients to get pulmonary embolism. Now, of all the causes, the challenge is in diagnosing and, differentiating between the cardiac and the pulmonary causes. They're also the most common causes to bring a patient to the emergency. In cardiac cause, the cough is not prominent after dyspnea. They will come with more breathlessness, and as and when you ask the patient about the cough, they're not very, conspicuous of this kind of cough. Whereas in pulmonary dyspnea, they have a history of cough. They have a history of cough, and they cough and then breathlessness. Orthopnea is again common in cardiac dyspnea, where a patient says, I'm more breathless when I'm lying down. As when I sit, it makes me better, which is not the case in pulmonary cases. And in pulmonary cases, you have sputum production in pneumonia, wheezing in pneumonia. They come with rhonchi. At times, you have this audible wheeze, which is not there in cardiac. Again, your urine output is normal in pulmonary cases, whereas in cardiac cases, because there is a fluid overload status, so the neck veins might be engorged and distended. You will see that there's, reduced urine output, and they usually benefit with diuretics. This is an X-ray, which tells us about acute pulmonary edema. In this, X-ray is one of the, again, important diagnostic tools because it helps us. It helps us to differentiate a cardiac and a pulmonary cause of breathlessness. Now, there is a measurement of the dyspnea that we do. It is the MMRC, the scale which we follow, in which there's a grading of dyspnea which is made. So this again goes to the history, as in when you're taking a history from the patient. You also asked him how the breathlessness is acute or chronic. Did you have sudden onset? We have people coming in and saying that, I was all fine till about 11 a.m. and then I had sudden onset breathlessness. And then this all started. It's worsened, and the patient comes. At times, we have patients who come to us and tell that no, it was very gradual. Initially, I could just when I had strenuous exercise, that's when I had breathlessness. So, what this grading does is grading helps us in differentiating the patients depending on the what do you say, severity of dyspnea. Because in the emergency, it is very important for us to grade the patients, to triage patients, because we have all patients who walk into the emergency, there's a panic button which kicks in and everybody feels they're sick. But how do you make out who requires priority of care? How do you make out who comes to which zone? And in our ED, all dyspneic patients we always receive in the A zone, because, and then we differentiate, and when we see no, they're stable, we shift to B and C zone. So coming to the grading, grade 0 is where there's no breathless as it is, but when there's exertion, when there's strenuous exercise, that's when they feel breathless. Grade 1 is when they walk up the stairs, they feel breathless, and otherwise they're okay. Grade 2 is when they walk in a normal level, even when they're walking, they had to stop for breath once in a while. They feel breathless on walking. That is grade 2. Grade 3 is the patient can't even walk about 100 meters. After a few minutes, patient has to sit and, gets breathless just after a few walks. So that is grade 3. And grade 4 is they're too breathless to even carry on with the daily activities. Dressing, undressing becomes a challenge for such patient. So this is the MMRC grading of dyspnea. Now, as I said, the approach to a patient with shortness of breath is very important. It's very important from the history onwards. So history, physical examination, and arterial blood gases, the SOB biomarker panel, the ECG, the point of care ultrasound, and a chest X-ray. These are the basic workup which needs to be done to assess the patient and treat the patient. As I have always said, history, as I've mentioned as well, history pulls you through. If you have taken a detailed history, if you have taken so detailed history means is a onset, is acute, chronic, how severe is it, and does it wake up the patient at night? Is the patient able to carry on with the daily activities? What brought about the breathless? Was there a fever? Was there a travel? Somebody in the house has it, a fever, and then you got it. A recent diagnosis that has been made of, or somebody, who's been through a chemotherapy session, somebody who's a malignancy been diagnosed, history of trauma, everything is very important. Even for pulmonary embolism, even if it is acute onset breathlessness, you would have a history of bedridden status, everything, So it is very important to take a detailed history and also past medical history. Past medical history of asthma, COPD, everything comes here. Also, here, diabetes, in comorbidities, diabetes, hypertension. Again, a patient who's diabetic hypertensive has also high chances of going into heart failure. And also, at the same time, a diabetic patient is also risk of developing diabetic ketoacidosis. So it's very important you take a detailed history here. Then come to the physical examination. As and when you examine the patient, so when a dyspneic patient walks, or a patient with shortness of breath is brought into the ER, we first check the saturations. Very important. We check saturations, check the vitals, pulse, BP, saturation. Put the patient in A zone and connect to monitor. Check the rhythm on the ECG. So these are the important steps which helps us to stabilize the patient. Invariably, all patients, as and when you are examining, you check the saturation is low, we connect. The first thing we do is connect to oxygen. We take arterial blood gases. What the ABG tells us is, ABG tells us about the basic, carbon dioxide, oxygen levels in the body. It tells us about whether there's an acidosis, whether there is a carbon dioxide retention, how are the metabolic parameters, how the bicarbonate is. It gives us also an impression on the sugars, acidosis, everything it gives us. So ABG is very important. Ideally, again, for all patients in the emergency, when you do a blood gases, ABG is, dyspnea is one of the causes where we need an ABG. We don't trust a VBG because the parameters have to be very accurate here. The next is the SOB biomarker panel. Now, what this panel is, it's a shortness of breath biomarker panel. It is a very new thing which is available in our emergency department as well. So what this has is, it has TROPA, it has CKMB, it has myoglobins, it has D-dimer, and it has BNP levels as well. So it is very important. Now somebody with a breathlessness, trop being elevated, okay, it is a coronary syndrome. Somebody with a very high D-dimer, as and when you do a SOB biomarker panel, when you do a D-dimer and then you find that the D-dimer is very high, there is again, risk of pulmonary embolism. This patient might have had a pulmonary embolism. This patient D-dimer is also a guidance. It also guides us towards infection, so sepsis. All these things come as one bedside test. It's a point of care test. The last thing which is very important in the SOB biomarker panel is the BNP. So BNP tells us whether the patient is in heart failure or not. At times clinically, we are not able to we are not able to find out whether patient is in failure, patient is in sepsis, whether sepsis is bringing about a failure, or is it the sepsis that is causing things? In these cases, the biomarker panel helps because it's a bedside test. It comes in half an hour and you get to know the D-dimer, BNP, all the cardiac exams in one test. So once that, we do the ECG. ECG is again very important. ECG can show us an MI. Again, in a pulmonary embolism, even if they say ECG, we'll have S1Q3T3. Very important is sinus tachycardia. In most of the cases of dyspnea, what we get in the ECG is sinus tachycardia, unless there's an MI, unless there is an arrhythmia which is picked up. Critical arrhythmias are also even picked up on an ECG, and that's how okay, this would have been the cause to have brought about a breathlessness. At times, patients might even show bradycardia. So anything is possible in a dyspnea patient when you do the initial test. So it is very important we do this bedside test. Next is a point of care ultrasound. It also includes a lung ultrasound as well as an echocardiogram. So what it shows is curly B lines. It shows us on the lung, it shows us the ultrasound, and the echocardiogram will tell us whether there's a regional wall motion abnormality, how the inferior vena cava is, how the contractility of the heart is there evidence of pulmonary edema, is there minimal pleural effusions. Everything we get to know from the point of care ultrasound. The last test is a X-ray, chest X-ray. And remember, we don't shift such breathless patients to the X-ray room. We get a bedside X-ray. And why we get a bedside X-ray is to rule out heart failure and to also differentiate heart failure from pneumonia, which is very easily picked up on an X-ray. If it is pneumonia, you will get lung infiltrates on the chest X-ray. If it is pulmonary edema, you get kind of this interstitial edema and blunting of the CP angles is what you get. If it is asthma, the X-ray is normal. So that is why also it's because severe asthma, you might not be able to differentiate initially. So that's how you have to get a chest X-ray done. Now, next we come to the treatment in the emergency. Anybody who comes to the ER, the first is always ABC, airway, breathing, circulation. So when the patient is brought in, initially assess initial stabilization, and there's a team approach. So when the patient is in the ER, patient comes in, we get the saturation probe connected, we connect the oxygen. Initially we don't know whether it's a COPD patient. If it's a COPD patient, the patient might not require high flow oxygen, but we don't know. Patient is just brought in breathless, diaphoretic, sweating profusely. We connect oxygen, we check the saturations, we get initial vitals, pulse, BB, everything checked. Connect to the ECG, connect to the monitor to check for the rhythm. Get the basic, evaluation done. And it is very important because this patient might be just a normal breathless patient coming to somebody who is an impending failure, who is an impending arrest. So once you do a stabilization, once you do a airway breathing circulation assessment, it's you don't miss out on things. That's what it becomes very important. As and when you see the patient is in altered mental status, patient is drowsy, breathless, very drowsy. This drowsiness could be brought about by anything. A breathless patient comes to the emergency and is drowsy. It can be some kind of a poisoning, some kind of a overdose of medicines. It could be a carbon dioxide retention. A person with chronic obstructive pulmonary disease usually has CO2 retention, carbon dioxide retention, and that might have gone to a considerable extent to bring about drowsiness. So they come as altered mental status. So at times it might be a CVA, it might be a neuromuscular disease, a disorder which has brought about altered mental status. The second thing about intubation is somebody who's in cardiovascular compromised status. BP is very low, saturation is low. Patient doesn't look good. Patient looks cyanotic. Anything you go ahead and you have to, and you feel that the patient is a threat to the airway. The patient is not able to manage the airway. There might be an airway compromise. You have to secure an airway. How do you do it? Is immediate intubation. Intubation is also to be done early in patients with anaphylaxis. Now, what happens in anaphylaxis is these patients in anaphylaxis, when the patient comes to you with history of anaphylaxis, they have a history of acute onset breathlessness, usually brought about by eating something or exposure to an allergen. So what happens in such patients is when they have breathlessness, you also ask them for hoarseness of voice. If there's hoarseness of voice, breathlessness, and when you examine, you see there's swelling around the lips, there's swelling in the oral cavity. These patients, and again, burns or inhalation patients, inhalation injury patients who come as breathless, in these patients, you go ahead and tube a patient early. You do an early intubation. Why? Because the swelling might increase and it might be a difficult intubation. And you might have to secure the airway with, rescue measures, with the other procedures. So it is always intubation for altered mental status, patients with impending arrest, patient with cardiovascular compromise, patient who has a history of intoxication, patient who has a history of inhalation injury. In these patients, we go ahead and tube the patient and connect them to a mechanical ventilator. Now, when you have done the initial investigations and you find that there's an examination, there is crepitations in the basal crepes are there, patient has a history of diabetes, hypertension, CKD or coronary artery disease in the past. Patient comes in a fluid overload status, very high blood pressures, pedal edema. These are, and you've done an X-ray, it shows pulmonary edema. You've done an echo, it shows pulmonary edema. These patients, what happens is also when you do blood gases, usually pulmonary edema patients, they might also have carbon dioxide retention. So in these patients, if the patient is alert and cardiovascular status is okay, then we go ahead and start them on NIV, which is a non-invasive ventilation. Now, what is non-invasive ventilation? In this, what we do, we put a high pressure mask to the patient and we put a high pressure mask and then we connect them to the ventilator and where we connect them with an inspiratory pressure and an expiratory pressure with an FiO2. So how it helps is when you put a non-invasive ventilation, it takes care of the saturation. Also, it takes care to release the carbon dioxide from the body. So this is what it is. But NIV should always be started in patients who are alert. Mind you, if your patient is drowsy and you've started on NIV, the patient might, the secretions might get compromise the airway. So we never start NIV for a patient who looks to be very sick, who looks to be very drowsy, who looks like who will deteriorate. We never start the NIV on such patients. Invariably, apart from this, the other patients, all other patients need to be started on high flow oxygen if they are dystic on arrival. Stable patients. Now, like I said, the multiple causes of dyspnea, and once you have stabilized the initial part, we then come to the what is the treatment based on the diagnosis, and this also tells us on the differential diagnosis of dyspnea. So, after you have stabilized the airway breathing circulation, you have got an IV access, you have taken the initial blood samples, and when we take the initial blood gases, we have got an ECG done. After that, when you put an IV access, we also take the blood for CBC, the kidney profile, we take for the cultures if we suspect pneumonia. So all those comes in the etiologic treatment. So what we do here is, supposing some patient has come to you with a history of trauma. There's a trauma and the patient is brought to the emergency. Patient is very breathless, saturation, can't feel a BP. You see that, absent air entry on one side, and then in that case, you go, and if you have done a clinical diagnosis of tension pneumothorax, you don't wait for an X-ray. You don't wait for anything else. What you do ahead is you do an immediate chest decompression by needle thoracotomy. And then, as and when needle decompression is done, you next in the line is your tube thoracotomy. You prepare for a tube thoracotomy per patient. Now, a trauma patient might just come to you with history of breathlessness, but then saturations and all are all okay, not that bad. Patient is stable. You've done an X-ray. In the X-ray, you find that there are multiple refractures. And what happens when there are multiple refractures? There'll also be some pulmonary contusions, so which is very painful. The refractures are painful. From the sharp edges of the ribs, there's a pulmonary contusion which is developed, which is equally painful. So in these patients, you just have to do pain management. So they usually require pain management. Now, again, inhalation injury, somebody with trauma, somebody with inhalation injury, closed room, suffocation, inhalation injury, carbon monoxide poisoning, anything, you go ahead and tube the patient early. So this is the kind of patients will deteriorate. So you have to start them on early intubation. This is the trauma part. The next part is anaphylaxis. What is anaphylaxis? Anaphylaxis, in a patient with anaphylaxis, what happens is these patients come to you with a history of an allergen exposure. They come with an acute onset breathlessness. And when you see there's hoarseness of eyes, there is breathlessness, swelling around the lips, there is because they go and develop the glottic edema. So in these patients, again, if required, we do endotracheal intubations. At times, it so happens that intubation is not possible because so much of swelling would have settled, you were not able to go through. In that case, cricothyrotomy, which is a rescue measure. Such patients, again, require IV steroids, IV hydrocortisone, epinephrine, and nebulizations, elevate the footing, give fluids, and antihistaminic, H1 blocker, H2 blocker, all comes in the management. The third is, again, pulmonary cause, pneumonia. In pneumonia, what you do is there will be history, fever, chills, cough with greenish phlegm, breathlessness. And when you check, you can find, on the chest examination, you find that crepitations. You will find, you might get fine creps, you might get reduced air entry, you might get bronchial breath sounds. In this patient, what we do is we start them on antibiotics, but before we start them on antibiotics, we also take the cultures, the blood culture and the sputum culture. Apart from this, there are also a lot of viral pneumonias, fungal pneumonia. Fungal is again, immunocompromised status where you get more fungal pneumonia. Again, viral pneumonia. So it is also important that you collect all the samples as well, for the flu panel, for if you're suspecting an exposure to a pneumonia, there's COVID, flu panel, everything, influenza exposure, you take the samples and then start them on adequate management. Again, ECG, like I said, if of the other cardiac causes, if there is these arrhythmias which is picked up on an ECG, patient is unstable, then we go ahead and cardiovert. Otherwise, we start them on adequate medications, antiarrhythmics. Dyspnoea, again, MI, you do an ECG, breathless patient, chest pain. You see there is an MI, so which has already been covered in the previous session. So you go ahead and treat them accordingly. Give them the cardiac medication, aspirin, and then plan them for a coronary catheterization left shift immediately. The other thing is heart failure. Heart failure, again, you as and when you've diagnosed a heart failure, you start them on diuretics. The most common is loop diuretics, furosemide, Lasix, we give them. We start them on nitrates, depending on how the pressures are. If the pain is an issue, and vasodilatation is also provided by morphine. These are the kind of patients where we start them on non-invasive ventilation, and it actually helps them in the breathing. Last is asthma COPD. Again, in these patients, they actually get much relief with nebulizations. So we nebulize them with bronchodilators, steroids, if required, IV steroids. And if it's a chronic obstructive pulmonary disease patient, also treat and infections there, we treat the infection. And COPD patients usually have a history of smoking. So we always counsel them to stop smoking, which most of them doesn't work though. These are, in a nutshell, about the common presentations in the ER and how we treat. Now, somebody who is in respiratory failure with any of the above causes, we go ahead and intubate the patient. Unless the patient is conscious, heart failure, carbon dioxide retention, and you feel that patient might not require an intubation, we go ahead with non-invasive ventilation. Now, the key learning points is a breathless patient walks into the emergency, usually presents with tachypnea, and it's a very dangerous, presentation. Very breathless, increased breathing, labored breathing. As and when, like I said, most commonly it's tachycardia. Most commonly they have they have a high pulse rate, high respiratory rate, low saturations, and most common patients to get such symptoms are the elderly people, hypertensive, and the diabetic people. Clinical presentation, again, is classically the triad of breathlessness, sweating, and agitation. At times, they're very agitated. They're very agitated because they're not getting breath. They're not getting the air. So they feel like they're deprived of that air. They're feeling like they'll die because of breathless. So they get very agitated as well. And such patients usually have a high blood pressure. If you talk about a patient with pulmonary edema, the BP is usually high. But if the BP is low, if you find that the patient's, pressures are low, the systolic is less than 90, most probably it is a cardiogenic shock. And these patients have a very high mortality. So they require very immediate treatment, immediate stabilization, immediate, treatment of the definitive treatment of the cause. Again, you don't need a lot of diagnosis. You don't need a battery of tests to diagnose. Only bedside chest X-ray, ECG, ABG. That helps us. That helps us to even know in which line we should proceed. Again, like I said, the SOB panel, the shortness of breath point of care test biomarker panel, which is very important, which is very useful, not only to diagnose MI, because it's not only the troponin I which is short, but also the D-dimer and the BNP levels. So you, in same setting, you get to know whether it's a heart failure, you get to know whether it's a pulmonary embolism, you get to know whether it's a MI. Then, as and when you do an ABG, most of the cases in asthma, you get type 1 respiratory failure, as in the oxygen is low, and carbon dioxide is not high. It's only type 1 respiratory, where there's only hypoxia, where there's only oxygen which is low. But in other cases, in failure patients, COPD patients, you might find the carbon dioxide has gone up. So these are the patients where, the non-invasive ventilation would help you, because like I said, it helps you not only to lower your to increase your oxygen and also to lower your carbon dioxide, which is more alarming because oxygen you can know from the saturation, monitor, you can know from the spo2 levels. If there's a carbon dioxide build-out and you have not done an ABG, trust me, you've missed out. And these are the patients who gradually become, drowsy, sick, and then you find that, patient is gone into an arrest, and then you get to know that carbon dioxide is shot of above hundreds. So it's very important that you do a ABG initially. Echocardiography, very important. Echocardiogram tells us on, it also helps us to rule out not only MI, fluid overload status, pulmonary edema. It also tells us whether the patient just has pleural effusion, because pleural effusion is also one of the presentations with dyspnea to the ER. In this, what happens, it's a gradual presentation. They have this breathless, and it has so happened that initially when you do all other tests, everything looks to be normal, but you still can't make out. That's when you do an X-ray and find out there's pleural effusion. But even before you do an X-ray, when you just put the, when you do an echocardiogram and then you put the probes, you know that in the lung fields, there is fluid accumulation there. Now, when you start treatment for such a patient with breathless, it is very important to make the patient comfortable in whichever position they find comfortable sitting most of the time. So when you make them lie, when you make them in a supine position, they get more breathless. So these patients are always a challenge to manage.
Yeah.
Because once the patient is finding it very comfortable, once the patient is comfortable in seated position, they refuse to, sort of lie down, even for a X-ray, even for an ECG, even for an echocardiogram. So when you do echocardiogram for a person who's seated, you get a poor echo window. You cannot basically find out what is happening because the patient is so breathless. He'll simply lie down and you're not able to do the test properly. Same thing happens with an X-ray. You getting a bedside X-ray. The patient is not allowing you. Patient is tilted. Patient is just not letting you perform your test. So this becomes a challenge. So, and usually what they prefer is sitting. They sit forward and they feel, okay, that makes them better. So that's what it is. And then such patients, we administer high flow oxygen, IV nitrates if the BP is very high, and NIV as and when appropriate, depending on the initial evaluation. And these are the references. And thank you.
Thank you, Dr. Suja. I think it was a very, very elaborate session, and I don't think so too many doubts will be there. However, if any such things are there, we'll just put on the chat box because we are already